All right, good morning, everyone. Thank you so much for coming. 9 o'clock a.m., bright and early. This is good because about 5 minutes ago, I think we were having a little bit of a rally call. So thanks for getting up early and for joining us for this session, Advancing Health, Virtual Care and Patient Engagement, and Ontario's Health System Priorities. I'm Vanessa Williamson, our Regional Director of Business Development at OCE, as well as our Sector Lead for the Advanced Health Sciences sector. I'd also like to remind you, if you're tweeting today's session, please use the hashtag OCE Discovery.
Sessions are beginning now. Please take your seats.
All right, apparently we're a little early, which is a first. So it's my distinct honor to introduce the moderator for today's session, Matthew Johnson. He's a Senior Business Development Officer at OCE in the Central Region team. He leads the delivery of our Advancing Health program, which we will speak a little bit about today, and brings more than 10 years experience in both public and private sector technology development, primarily in the medical and life sciences. As Advancing Health lead, Matt has worked with healthcare providers, industry, and academics to develop collaborative projects focused on demonstrating Ontario's leading health IT products and services in the public healthcare system. Welcome, Matt.
All right. Thanks very much, Vanessa. And good morning, ladies and gentlemen. Like Vanessa said, I'm Matt Johnson, and I'm delighted to welcome you all to this discussion. Again, thanks for showing up for a bright and early session. This session will discuss the growing pull for innovation in our healthcare system and the need for evidence-based assessment of emerging technologies which enable virtual care and patient engagement. Panelists will share their different perspectives, those of government, clinician, innovation lead at a regional hospital, large and small technology companies serving the healthcare sector, and hopefully shed some light on how these different pieces work together to support adoption of solutions that will educate and empower patients to self-manage their conditions at home, and will have the potential to promote efficiencies and allow for long-term savings in the healthcare system. So before we begin, I'd like to take this opportunity to introduce our panelists. For their full biographies, I refer you to the Discovery mobile app and website. So first to my left is Pat Clifford. He's the Director of Research and Innovation at Southlake Regional Health Centre. Pat is charged with leading the development and implementation of Southlake's research strategic plan and advancing the commercialization strategy, which includes developing Southlake's incubator for health-related innovation, Create It Now. Our second panelist is Fraser Edward, Director of Business Development at TELUS Health. Fraser is a seasoned healthcare technology executive who works with public and private sector healthcare stakeholders, guiding them in adopting new and innovative care delivery models. With more than 18 years of experience in the wireless industry, he is passionate about the important impact that mobile, social, and IT can have on transforming healthcare for all Canadians. Our third panelist is Dr. Michael Hilmer, the Director of Planning, Research and Analysis at the Ontario Ministry of Health and Long-Term Care. Michael has been involved with many exciting projects during his tenure at the ministry, including developing the Chronic Disease Prevention and Management Strategy, the Trilateral First Nations Health Senior Officials Committee, and creating guidelines for multiple sclerosis care. His excellent work has been recognized with several awards, including the Ministry of Health's ACE Award, the Ministry of Children and Youth Services Pinnacle Award, and across the OPS with 2 Amethyst Awards. Our next panelist is Dr. David Krendler, Associate Scientist at Sunnybrook Health Science Center. David is head of the Division of Youth Psychiatry and the lead for the Center of Mobile Computing and Mental Health at Sunnybrook Health, as well as an Associate Scientist in Evaluative Clinical Sciences at Sunnybrook Research Institute. He conducts research into clinical applications of handheld computers in mental health, as well as mathematical modeling of mood disorders. And finally, our fifth panelist is Dr. Joshua Liu. Josh is a physician turned entrepreneur who believes that the future of healthcare depends on the intersection of design, data, and technology. He is the co-founder and CEO of Seamless MD, a healthcare technology company which provides a patient engagement and remote monitoring platform for guiding patients through surgery. Joshua is also a startup advisor to Northeastern University and has been named a Forbes 30 Under 30 in healthcare and Canadian Top 20 Under 20. So I am pleased to welcome this distinguished panel, and also all of you who have an important voice in this discussion as users of our healthcare system. I hope you'll consider this conversation, the information here, and think of great questions for the panel, though I ask that you please reserve those questions until the Q&A period following the discussion. So let's get started. So first, innovation is a real trending topic lately in Ontario's healthcare system. From the bottom up, with many hospitals and clinicians starting grassroots in-house innovation programs, and top down with different government ministries gathering stakeholders to take a close look at opportunities for improvement. So examples of that include the recent Ontario Health Innovation Council report, as well as the report of the expert group on home and community care. So starting from the government and provider perspective, what are the kinds of forces driving this reflection and resulting action? And I'll start with Michael there.
Great, thank you so much. So thanks for inviting me to the panel and to all of you for coming. The Ontario Health Innovation Council is the government's major, in your words, top-down effort to improve the ability of the healthcare system to be receptive to adopting innovation. And what I really liked about the report is that first it was driven by a dozen or more of the key health system leaders, and led by Dr. Dave Williams from Southlake. So any of you who know anything about Southlake and Dave Williams know that he's a real champion of health innovation and puts his money where his words are, and actually sets up interesting collaborations between industry and healthcare providers. And so that spirit drove the deliberations of the council. And they took a broad view of innovation. It wasn't just the new piece of technology, it was process innovation, management innovation. So they really took that view of Gary Hamel, that you've got an innovation stack that you can look at innovating around process and operations and different models of care, all the way up to how you manage the system. So their recommendations really were about engineering a cultural shift in the way the system looks at innovation, identifies it, procures it. So they really did take a broad view. And in terms of the driving force, it was really that we have 13 million plus people in the province who need the best health care in the world, and a budget that keeps growing and growing. And innovation is clearly one way that you can start dealing with some of these challenges, by looking at new ways to bring higher degrees of efficiency, satisfaction, engagement. And I think the panelists today will talk about different initiatives they're involved with that are doing that. And that was the council's role, starting to create that pull. Because There's no shortage of amazing ideas out there, but the pull into the system was probably always the weakest link. And we hope by starting to implement the council's recommendations, that pull can really be strengthened.
Yeah, it was really exciting to see those recommendations supported in the budget announcement on Friday. So really exciting for everyone in the healthcare innovation community. And so I want to go to the providers on the panel. Maybe, David, I'll start with you. If you could share some of your experience, in particular working with patients and researching sort of mobile solutions for aiding patient care.
I've been thinking about how to go about addressing this question, because it's a tough one. Yeah. There's a couple of pieces to it. I think from the point of view of the clinician researcher on the ground, basically there's a pull and a push. The pull is very much like what Michael was talking about, progressive introduction of government funding programs. The push has been the corresponding cutback in the amount of money which is available for pure research applications or to support basic research. And so essentially, of necessity, anybody who has any sort of technology or apps or development which are able to have some potential for commercialization is obviously looking that way. But at the same time, though, I think that there's also essentially a growing culture within the hospitals and within the universities to try and support innovation and commercialization. So for example, the creation of Mars over the course of the last 10 or 15 years. When I first got into this, you started talking about intellectual property protection, and you more or less had to figure out what your own approach was to things. These days, there's a much more robust, although not necessarily as robust as might be nice, kind of apparatus in place. There's still a bit of the challenge for clinicians who are interested in remaining clinician researchers, how you go about trying to innovate and commercialize an application without essentially having to hive off 50% of your time to turn yourself into a businessman. Josh may be able to speak to what pulls somebody one way or the other, but it's been a bit of an ongoing tension from some of our points of view anyway.
Right. And so, Pat, I wanted to ask you too about your experiences with Southlake, who I've observed to be really at the front of this sort of grassroots, innovation effort in a community or regional hospital, which might not typically be expected. And so I'm curious about sort of how that started, what sort of, if you want to call them market forces, originated there, and how you ended up sort of doing what you're doing there.
Yeah. Matt, I think it's a constellation of really quite a variety of things. And certainly one of them, has to do with leadership. And so when you talk about sort of, innovation and commercialization in the health sector, leadership is certainly part of that equation. So I spoke a moment ago about Dr. Dave Williams. So I'm very fortunate in terms of Southlake in bringing Dave on board as our CEO, coming from a long track record both as a physician, as an astronaut, and running the life sciences division at NASA. And so really bringing that commitment, that passion to science, to quality, to patient safety, and to commercialization. And Dave tells the story, and I won't tell it as well or as detailed as he does. But he talked about when he took over the division at NASA, that when he kind of traveled around this first 6 months and was sort of asking folks about what are your accomplishments here, they would talk about the number of peer-reviewed papers. And that was wonderful, and it was an academic focus, and so that all made sense to him. But he really asked about, based on the investment in technology and products that wind up going into space, how is that being commercialized and getting out to the U.S. market? Mm-hmm. And was kind of greeted by blank stares. So that was part of what he did over his time there, coming back to the Ontario context, coming specifically to Southlake. Really was a huge inspiration for us as a large community hospital to really look at the drivers on healthcare. So the dollar value that is invested in acute care and long-term care in the healthcare system across the province, the degree to which that is really truly sustainable or not, and we know that it isn't in its current format. When we look at our patient population, both at Southlake but across, again, the province, in terms of sort of 1% of our population using almost a third of acute care services, 5% using almost 60% or 65% of acute care services. So we have to deliver healthcare in different ways. We have to be innovative. There are technologies, there are products, there are services, there are process innovations. All of that is out there. Right. We have not done a good job. Right. At really being able to capitalize on it. So that's where we got started.
Right, and so now I want to ask Fraser and Josh, who are on the private sector side offering solutions, products and services in response to this poll. What has your experience been? Are you seeing a resulting increase in demand for the kinds of solutions you're offering? And how does Ontario differ to other jurisdictions where you do business? Fraser, I'll start with you.
Ontario is definitely different. The challenge I see in Canada is we have such a fragmented system. We don't have one healthcare system. We don't even have 10 provincial healthcare systems. We also have 3 territories and 4 federal departments. So we all want something slightly different, and that's a challenge. Secondly, Ontario, the way we're set up, it's very fragmented again into each hospital. So I think one of the challenges I see is everybody's kind of reinventing the question. Mm-hmm. And starting from the beginning again. And I think we lose time. TELUS is primarily a telco. We have a large investment in healthcare for sure, but I mean, what does a telco do? They take something that is big, that lots of people want, and they then put that on to a bill so people can have that wherever they are. I think in healthcare, some of this stuff, we want to be different each time, and I think it's sometimes a lot of it's good enough. And
Right.
if we could just agree with the key things we're trying to do and focusing on the patient versus the academic research publication, some of these things I think would help focus us down. But yeah, Canada's definitely different for sure.
Josh, what are your thoughts?
Yeah, so I think there are three main forces in the last couple of years that have really driven innovation and actually made companies like ours possible to exist. Number one, with the unsustainable funding of healthcare the way it's done today, there's been a dramatic shift ongoing from a fee-for-service world to a fee-for-value world. So number one, that's driving an urgent need for new ways to do things at scale. Number two, the explosion of mobile devices and connectivity with the internet has created this unprecedented opportunity to actually bring healthcare into people's pockets, into their homes, through their device, through their desktop. And certainly, 5 or 6 years ago, that penetration wouldn't have been high enough for a company like ours to exist. But now, today, there are over a billion mobile devices worldwide. Certainly, almost every person on the planet will be connected to a device, to the internet by probably by 2020. And so, for the first time, you can bring healthcare outside the walls of a hospital or a clinic. And thirdly, the cost to actually build software and technology and deploy it is much, much cheaper. And so, all the right forces are at play to actually make this possible today. But to kind of connect with Fraser's point and the difference between, say, Canada and the work we do here and the work we do in the US, force number one is quite different. Certainly, I think in the States with the Affordable Care Act or Obamacare, the shift to pay for performance or fee for value is much, much stronger. And there are harsh penalties for readmissions. There are new bundle payment programs that are spreading quite widely where groups are paid for an entire episode as opposed to bits and pieces of care delivered across an episode. And so what we're seeing is that it's the changes in policy and the changes in economic incentives that's actually driving innovation. So, when I think about innovation, I don't think the goal is to just do more healthcare innovation. I think the goal is to get the best outcomes and the lowest costs. And I think if you align the incentives the right way, the innovation will come naturally to help fulfill the need to meet those incentives. But until you change the root incentives, I think it's going to be hard to get innovation the way you want it.
Okay, that's interesting to see that. Oh, there you go. Yeah, sure.
You hit a nerve.
It's interesting that the differences in the markets here and in the U.S. and a lot of our companies target the U.S. first, and I think part of what we were talking about earlier, kind of this overall drive to improve adoption of innovation in Ontario is kind of in response to that. We have all this great stuff here, and we should see the value of that in our system first, or at least second. And so I want to go back to the OHIC report for a second. One of the interesting things in there was a recommendation that information communication technology, software enabling virtual care and patient engagement, that these should be prioritized for assessment for evidence-based adoption in the health system. And so I wanted to ask if Michael, if you could expand on the discussions that were behind that recommendation, and what are the kinds of clinical scenarios that we're talking about in wanting to see these things adopted?
Sure. The panel, I think, just saw the clear value proposition of a virtual visit and looking at some of the leading systems in the United States. Kaiser's probably close, if not already past an inflection point in terms of virtual visits, outnumbering face-to-face visits, and I don't know what the percentage would be, but it's probably a pretty large one that could easily be amenable to a virtual visit in terms of the number of total clinical visits that are happening right now. And this is a crowd that's probably read Eric Topol's book, and he lays out the compelling vision of the future. And I think it was that exact conversation that was happening around the table with the health system leaders that were the individual counselors thinking about what are the ways in which mobile technology and virtual visits, how can they support care, both reading diagnostics in terms of thinking about, is there a pool of available providers who can asynchronously read an image and get a result back to a patient quicker, or is there a way in which an idle provider can just log on and pick out of a queue somebody needing counseling, so that you break down this antiquated model of needing to make an appointment where there is somebody there to see you when we have the technology to do it. So the council was very driven by that idea that the technology is clearly here, hundreds and hundreds of industries have figured it out, but there just seem to be this systemic barriers. And I think Josh pointed out very clearly that the incentives haven't been aligned. And now that in Ontario we're moving to more fee for value and starting to dabble in the episode-based funding models, that those kinds of solutions that will enable that will just hopefully become more ubiquitous.
Right. And so, David, I know that you've been doing this for a while, working with your patients and sort of applying mobile communications and mobile monitoring type solutions. I wonder, what's your experience been? What sort of benefits have you seen, that with your patients and their outcomes that might sort of drive this interest in more broadly assessing these kinds of technologies?
Well, there's a number of factors to it. The work that we've been doing, we've been working with what we call mental health telemetry, monitoring people's mood symptoms over time by way of trying to essentially improve the paper and pencil mood journal since about 2000 or so, since basically not quite the dawn of the cell phone, but shortly thereafter. There's a variety of factors. There are technology, at least the kinds of technology that we've been using in clinical psychiatry, seems to be quite well accepted and quite well tolerated by a certain subset of the population. The ones who do seem to do a far better job of making use of it than they would if we asked them to do the same job with paper and pencil. It's more convenient. You can get data sets which are far richer than you could possibly manage with paper and pencil. It's far more open to being analyzed. There's a variety of potential applications to it as well. I mean, one thing about technology is that it's geographically independent. I used to work in an underserviced area clinic in Parry Sound. There are people there who are dependent on their car to be able to get into Parry Sound. If they ended up not being able to drive for medical reasons, they wouldn't be able to see anybody. Being able to keep track of how they're doing by cell is a whole lot easier, since their cell phone service is much less geographical than being able to schlep into the doctor's office to be able to see somebody. I think I got a little bit off topic there. I'm sorry.
No, that's fine. I mean, it's where these things are. Again, I think a lot of people understand that there's a value proposition there. It's these kind of real world examples and the interaction with the technology. On the patient side, it's important to understand all these factors, because they're all important to inform this evidence base for their adoption. And so I wonder if Pat, if you could share some challenges with your patient population or in Southlake. Is there what sort of applications of these things, these kinds of solutions could you see helping?
Yeah, I think the quick answer, Matthew, is really the sky's the limit.
Right.
Again, getting back to kind of the delivery of healthcare, it has, and certainly will continue to change dramatically. So the bricks and mortar concept of bringing individuals into hospital for routine follow-up visits, for monitoring of their chronic illness, and whether that's mental health, whether that's cardiac, whether that's respiratory, cancer care, across the continuum. Many of those visits are not required in terms of an acute care or an acute care facility. They can be provided in novel ways. They can be provided by face-to-face interactions over video. Mm-hmm. They can be provided in data collection through applications, education related to disease management, self-management, management of chronic illnesses, all of those things. So name your illness.
Right.
And for certainly the vast majority of those, care should be effectively delivered in ways that do not involve bricks and mortar. So there will always be a place for hospitals, there will be a place for professionals in the community, there will be a place for long-term care services. So there will always be places for individuals to come. What will change is that what will bring individuals to the front door.
Right.
And so the acute needs that need to be managed in an inpatient space are those individuals that hospitals are going to look at treating in the future. Those that are able to manage at home are able to manage at home with 24/7 support, with applications, with being able to check in with clinicians that are available to them in ways that are not available now. But to do that remotely, do it by smart technology, that is going to become the way. And so South Lake sees, as all hospitals do, all sorts of opportunity there.
Yeah,
It's
no,
immense.
I think it's really an exciting time. This concept of patient engagement, and I would even expand that to caregiver engagement too. I think it's understood that there is billions and billions of dollars of healthcare value delivered by families and caregivers.
Absolutely.
And so if we can better inform those caregivers, enable them with the right information and the right sort of processes to help their loved ones at home, it improves care for everybody. And these people, they're working for free, and they'll do it. They'll work their butts off for their loved ones. And so I think to give them the tools to help them do that, I think it's there's just huge potential for that.
Yeah, absolutely.
And so go back to Fraser and Josh, in your experience, in bringing your technologies to market. I wonder what sort of feedback you're getting from clinicians and patients, and if you have any, if you can report any interesting metrics and health outcomes and satisfaction, user satisfaction. Josh?
Sure, yeah. So definitely the feedback has been incredibly positive across the spectrum. From a provider point of view, we're hearing things like less phone calls back to the practice because all of the obvious things are given to the patient in terms of education in a timely way. We're hearing from patients that they're actually now kept on track in their journey through surgery. We've had stories about patients who would have missed their surgery or their appointment if not for a reminder on our program. And we're looping caregivers in as well because they can also receive the same information and keep their loved one on track. I think one of the biggest learning points for us has been that accessibility is incredibly important. So shifting the way we think about our solution from it's just an app to rather it's a new modality of delivering education and engagement, and our job is to engage and educate the patient in the way that they want to be engaged based on their access. So, when we started off, we were purely a mobile application on a smartphone or tablet, and that worked great for people who had that access. But as we got more and more feedback, we started incorporating a web-based program. We started incorporating text messaging and email. And so, we were getting both younger and older people getting engaged and educated using the access that they actually had. And so our model shifted from just building an application to building a real program with different ways of accessing and engaging patients. And in terms of the success from it, I can give a couple of cases. So we did a lot of work last year with Toronto East General with their thoracics or lung cancer surgery department. And one of their challenges was they had quite a few cancellations on the day of lung cancer surgery, which was not great if you're having lung cancer and you need surgery soon, but it's not great for the institution from an operational point of view. And usually it was because patients forgot to stop blood thinners on time, they were eating after midnight, a lot of preventable things. And so, once our program went to the pathway and patients started getting information at the right time in their care, cancellation rates on the day of surgery dropped from 6 in a 3-month period to 0 over the next 11 months, with terrific satisfaction engagement from patients who are often in their 50s or 60s. At another organization, one of the things they did with us was they collected satisfaction and experience data after discharge, after surgery through the platform. And what they noticed was that when they were doing this by paper and getting data 3 months later, they were getting 20 times more response rates on the platform, and they were getting that data as early as a day or two after discharge. So they were getting more data significantly. They were getting it in real time. They could actually drive local quality improvement because they're getting more data sooner. And so I think we've certainly seen that technology has played a great role in helping organizations get useful data earlier so they can drive better experience. and we're getting high 80% satisfaction in terms of it's better than my paper instructions I'd recommend to other patients. So certainly the uptake has been very good. We know we have to do more work around still getting better and better access to all types of people, and we know that 100% penetration is not going to happen anytime soon, but we're doing everything we can to work towards that.
Yeah, I guess it's one of the challenges with technology. As much as we think it's ubiquitous, there are still a lot of users, in particular in certain demographics, that might not have access. I think it's great that you're learning from your testing and sort of expanding the accessibility of the platform, as best you can, listening to your customers, right? And so, Fraser, I wanted to ask you as well. I know TELUS Health has been deploying remote care and telemedicine type solutions for some time. I wonder if you could share your experience in that business. What sort of, related to user satisfaction and health outcomes?
I think the tuition value of these programs is great to take and share. I think Ontario telemedicine is probably the most advanced in the world in this space, and I think it's, I don't know if you saw the Globe and Mail article a week ago, front page there was a section in the Monday edition where they were sharing some of the statistics. TELUS is a technology provider as part of that program, but the emphasis is the program, and the emphasis is bringing together not the technology, but all the pieces to make it work. The stats are good though. I mean, in terms of delivering care virtually, this is a program that's been used by 4,500 people in Ontario who have either chronic heart disease or COPD. The impact has been a reduction in visits to the emergency room. So after they are discharged from their acute episode, they're put on the telehome care program. The reduction in visits is ranging between 37 to 48%, and that's coming from your organization and a whole bunch of others across the province that are doing this. In terms of readmissions, and these are things that cost our system a lot. The reduction is between 44 and 57% reduction in readmissions. But mostly I think it's the recommendation rate of the patients on it. The average age of the patient is 75, and the recommendation rate is at 87% of them have been recommending that this is better care delivered to them. And so
Right.
I think the demographics of the age and the recommendation and just the sheer numbers that are coming out of the program, to me, says we need to do more of this in Ontario. And so there are specific disease states that were the obvious places to start. Mental health is another one. The challenge now is how do you bring it to more areas, really to more an assisted self-care model where other people in the system can take advantage of the same technology and solutions and access to care, but spread it more broadly.
Right. And so, that's a great segue to the next question. And from each of your perspectives, I understand this part of the conversation could go on for a while. It did in our kind of conference call about this, but I want to get, and we've sort of alluded to it a little bit already, but what are some of the real barriers? I mean, if you're seeing these kinds of impacts with deployment of these novel solutions, what are some of the barriers to broader system adoption? Why don't we start with Pat?
Yeah, there are a number of them, but certainly, I think
choose your favorite.
Choose my favorite. At a system level, one of the things as an acute care provider, as a hospital that we look at, are the procurement issues, and again, we've talked a lot about that. Folks in this room, I'm sure, know about them. So one of the things we really need to look at is that sort of innovation procurement of innovation piece, and how we do that in a more effective way, in a more streamlined way. How we're able to develop systems where we can work with emerging companies, technology companies, products and service companies that have technologies that are of relevance or of interest certainly to the acute care, long-term community care sector. Engage with those individuals, be able to work with those technologies, help those develop, and be able to bring them into the organization. Yeah. And right now there are a number of fundamental barriers in being able to do that. For altruistic enough reasons, but we need to think about how to streamline that process. And certainly the OHIC report talks about that, and really encouraged to see some opportunities now reach through HTX and some other things that are going to help us look at new models. So that's certainly one of the pieces.
Good. We'll just go down the line.
Keep going down, Ryan.
Fraser, yeah, what do you think?
My pet peeve is plugging it into the rest of the system. So it's the interoperability. I worked with startups for many years when I was at BlackBerry, and you have these great ideas. And as we said on the panel, then the entrepreneurs have to take half their time to figure out how to run a business. They probably have to take another huge amount of time to plug it into the systems that are in place. So if that's the information systems in the hospital, or even into some of the provincial pieces that are coming to reality. So I think our opportunity moving forward is to harness some of these new ideas and new ways of delivering care, but how quickly can we plug it into the Connecting GTA project, or as it expands to Connecting Ontario, or into some of the individual systems, so the data can be shared around and the value can be brought out the other side. I read so many of these reports. There was one from Nova Scotia a month or so ago where they had put in a big project, and the first page, I think it was the second paragraph, it said, but it did not plug into the electronic medical record that the physicians were using, so we didn't see the benefits we hoped for. And I think that's the challenge. We've now got more mature, and speaking as TELUS, we have a lot of VMRs and penetration into the primary care market ourselves. So I'm speaking as much to ourselves as I am to the government and other parts of the system. But we have to make this easier to plug the information in. Otherwise, we'll never see the outcomes and the benefits.
Yeah, that's great.
Great, thank you. I think you look at the OHIC report, and the council really honed in on some of those key challenges, and there's a nice life cycle of innovation, of healthcare innovation, where they have two specific, what they call it, valleys of death, where moving from prototype to larger scale deployment, and then if you do get lucky enough to get there, how do you commercialize and have that broad scale opportunity through procurement. So I think what excites me most about moving forward with the recommendations is that it's a range of structural, process-based, and symbolic moves towards innovation. The symbolism of having a chief health innovation strategist, I think, is enormous, because it shows the system has an individual who's charged with finding innovation and infusing that spirit throughout the system, but it's not as if they're just going to be a cheerleader. They're actually going to be within the Ministry of Health, because sometimes there are real barriers, like you can't get paid as a physician if you don't have a face-to-face visit. I think OTN is one model where that's breaking that down, but there are legitimate structural barriers that need to be broken down, and having somebody as a champion of what those are and how to get through them will be really positive. And again, thinking about the structural changes, this idea of the innovation brokers reporting into the innovation strategist, I think the council looked far and wide to the UK, to Israel, and tried to pull the successful initiatives from those jurisdictions in and put it in a package that makes sense for Ontario. And so I think it's not so much about what the challenges are, because I think anybody in this room knows, either painfully because they've butted up against them or they've studied them. It's about what we can do collectively to get through them, and hopefully we can ride this momentum of the adoption of the recommendations and everybody's incredible innovator-driven ideas, and start showing that we can get through them. And I'll give you credit for advancing health. I think that's one really prime example of how we can start breaking down these barriers by bringing innovators and providers and academics together. Because I'll just spend one last minute about a real challenge in the healthcare system is the evaluation of these types of initiatives. I mean, clinicians and providers are used to a certain level of evidence that comes from a clinical trial. Well, it would be hard to clinical trial Josh's solution, because for one, it's iterating constantly, so it's not necessarily the same thing day to day as new updates are deployed, and it's a whole package that you can't necessarily reduce it down to one ingredient. It's a big recipe that's hopefully going to create something that's amazing.
Yeah.
So I think learning from people like Eric Rees and how he helps startups get the evidence they need to demonstrate value is important.
Right, right. David, what's your experience in barriers to seeing so in mental health telemetry, for example, for that being a broad tool for adoption?
Right, so recognizing for the moment that this discussion is focused pretty narrowly on computer applications because there are other ways in which people can innovate in the healthcare system. Speaking to that anyway, one key area which I've seen which is an issue around adoption is around various aspects of human-computer interaction. So, for example, anytime that you're asking somebody to use an app, essentially what you're doing is you're adding another step to things. You're asking them to take care of typing things. You're asking them to somehow or other distill and compress information down into a form which can be entered, and then asking them to go through the process of that. And that's a hassle, which will sometimes be a barrier. A second piece is around how the actual information ends up getting used in the clinical encounter. So, for example, one of the reasons why a lot of psychiatrists are fairly reluctant to start using EMRs is because you end up, in the absurd extreme, oh, I'm sorry, Mrs. Smith, I'm sorry to hear that your mother just died. It detracts from the clinical encounter. The third piece is around integration into workflow. There was somebody at the American Psychiatric Association convention year before last who quoted a time and motion study of family doctors saying that if you walk into your family doctor's office in the States with a chief complaint of major depression, the amount of time that the clinicians will spend addressing that complaint is 2 minutes. So if you are trying to incorporate, for example, some sort of mental health record-keeping process into that, you have to find something which the family doctor will willingly shoehorn into the 2 minutes they've got allocated, which is a real challenge.
Yeah.
So, all of these are examples of things which need to be successfully addressed in order to get the innovation off the ground and used clinically in a way that's acceptable.
Yeah, those are great points. It's really a whole system and barriers at different nodes of that system at the procurement level, perhaps the government level, the clinician level, and the patient level. These things are all have to come together to see these things, really be successful and be adopted. Josh, any thoughts on key barriers for Seamless MD?
Yeah, I guess I'll talk a bit about kind of the barriers from the lens of a technology company trying to get kind of adoption scale more widely. I think, we talk a lot about, fragmentation and silos in healthcare delivery, and I think we kind of see similar fragmentation in the way we try to spread innovation. So for one thing, for example, as we go from hospital to hospital, for example, we often have to go through, say, privacy assessments and security assessments for technology. And what you'll find is that you have to repeat the same or similar assessment at every organization. And so to me, that's a waste of time and money for the healthcare system, where if these processes were unified at, say, provincial level, you did it once, you were approved everywhere, and aggregate takes a lot of time and money. The other challenge we see is that because it's not unified, different individuals, different organizations will interpret policies and set up policies quite differently, so it's always slightly different depending on the organization. And so as a outside party, it's hard to get clarity on what exactly we should do, and then that changes from organization to organization. And to make an analogy, I hear similar kind of complaints from clinicians and researchers trying to do academia across multiple institutions. I heard one physician recently kind of was really upset because he was trying to do an 8-site RCT, and he was applying for ethics at 8 different organizations. It was taking a year, and so a lot of these things could be unified processes, not just in technology, but also in research and evaluation. I think if there's a way we can unify these things and stop fragmentation, you'll see a lot more speed in research, innovation, evaluation across the spectrum, and from there, faster adoption.
That's great. So I'm looking at our time, and I'm looking at this large group that's somehow assembled around our panel, and I want to give plenty of opportunity for questions. So if anyone with a question wants to step up to the microphone, we'll take questions.
Thank you. My name is Gino Ariano. That was excellent, by the way. Thank you all. I have a healthcare consulting practice. I focus on helping early stage companies commercialize medical technology. But you got me thinking back to a time earlier in my career. Almost 10 years ago, I was at Medtronic, and I was responsible for launching a remote patient management system for patients who had heart failure. So these were patients with implantable defibrillators who could be managed at that time and still can be remotely. And there's a huge value proposition around that, as you can appreciate. You mentioned some of the things about reduced readmissions for heart failure, which is a huge cost to the system. But one of the key, there was a lot of barriers, and there still are, but one of the biggest ones was physician reimbursement and the ability of clinicians to get paid. And there's a lot of politics around that, but I think that's an area that really needs to be drilled down on, and I'm just wondering if the panel has any thoughts on that.
Yeah, so I wonder, with the implementation of the OHIC recommendations, is there sort of a concept of linking those efforts to drive adoption to a barrier like reimbursement and payment?
Well, I'm not going to...
We'll put you on the spot.
No, it's a good question, and I'm not going to speak for this individual before they even get there, but it was a topic of considerable discussion around the council table, so it's well known, and I think the process by which topics get chosen there will be a process. Where are some really high potential topics? Like I think heart failure is one that both is amenable to different kind of physical models of care and also virtual care. So just for the sake of argument, let's say heart failure is a topic for this office of the Chief Health Innovation Strategist first consideration. So I think they would start mapping out where the barriers are, and if it really was, how do you ensure the telemetry for a heart failure patient is reimbursed appropriately? Well, then that would be something that they would start to work on. And in terms of the mechanism, I can't speak to how that might play out, but you could imagine there would be small scale demonstrations of how it could be done differently, and if that was successful, maybe that would be a model for broader deployment.
To build that evidence base, right?
Exactly, to build up the evidence base, and not even so much the evidence base, but just, again, if you think of the OHIC recommendations, their first one was this is a culture shift that's required. So how do you get the system or the multiple interlinking subsystems that make up the province to be very comfortable with the idea that a visit does constitute looking at some important metrics while you're at home after you've put the kids to bed, and that's a reimbursable event in some future state.
Right.
So I think that's what the strategist might work on.
Good. We'll go to David there too.
I'm only familiar with the schedule of benefits for psychiatry. The full OHIP schedule of benefits is big, but to the government's credit, there has been some progress with trying to reimburse things. So, for example, telepsychiatric consults are covered. Phone consults, phone discussions between specialists, physicians, thereby hopefully saving the patient yet another visit, are now covered. So it's starting to move in that direction.
Right. That's good to hear. Thank you very much.
Hi there. My name is Pete Gassick. I'm from Sheridan, and we're exploring telemedicine technician and kind of that blending of the clinical and the technical role. So a shout out first, I'd like to collaborate with anybody who's here. And second, just interested in what you think the impact of telemedicine is on traditional roles that are in healthcare and how that's having an impact.
Fraser, do you want to try that one?
I was going to say it's probably more a question from the clinician perspective, I would have thought.
Okay.
Yeah.
And Pat, you want to take that?
Yeah, I think it's a great question, and I think it's an evolving one. So I think very much we will see the roles of clinicians change in this process. So we will see clinical care delivered in different ways, but we will see the role of clinicians change as well. We've been doing some work with one of our academic partners with York University around the health coaching model, and so again, very much looking at that notion again for individuals living with chronic illness. And because our lifespan, is now considerably longer than it used to be, and it will continue in that general direction, more of us will have the opportunity to live with chronic illness than we used to. We would die before we would have 3 or 4 chronic illnesses. Now we'll be alive to have 2 or 3. So, the good news and the bad news. So we're going to have to find, sort of other ways to not only be able to deliver that care, but to assist those individuals. And so whether or not, as much care will be delivered by physicians or delivered in the same way that it is currently being delivered, nurse practitioners, health coaches. So we will see technology very much become that connection between patient. Matthew talked earlier about caregivers and families, clinicians. So it is going to become that highway that is going to allow the delivery of care and the care providers, I think, to change.
Yeah.
Ron Becker, Technologies for Aging, Gracefully Lab, University of Toronto, and FamilyNet Communications. About 45 years ago, I spent 2 years at the National Institutes of Health, and one of the things that people were talking about was an electronic medical record. And I remember being very inspired by the early writings of Lawrence Weed of the University of Vermont about that work. And here we are 45 years later. What can any of us do as researchers, as entrepreneurs, as practitioners, as citizens to try to finally move this forward so that maybe before I die, at least all the medical information still that can still be gathered, which is very little of it, can be pulled together?
I do think it's the consumer voice. I mean, this is a country where you don't win an election based on healthcare, but you'll definitely potentially lose an election based on healthcare. I think we've seen in every other part of our life the value of some of these pieces. And so I think the challenge with healthcare is until you're in the middle of the system or you're caring for a loved one who's in the system and helping them navigate, you don't realize that it's not all electronic. I mean, my dog's got an electronic medical record. It's shared across all the vets anywhere, and I realize there's differences, and I'm overly simplifying it. But I think it's got to be the consumer voice that says this is important, and we applaud the government in terms of what they're trying to do here, and they're being brave. And even if mistakes have been made in the past, we can't give up. We got to keep coming back to it. So I would say a consumer or a voter voice is one thing we can all do.
Anyone else?
No, I would just add to the consumer voice that don't underestimate the power of some of the fee for outcome models that Josh was alluding to earlier, in that if you prioritize the funding of a particular outcome and allow innovation and process to fall underneath, then I think you can drive a whole different equation that way, one where information technology is more prized because it allows you to do things more efficiently and quicker. And so I think those two forces combined will hopefully, drive the adoption to see the point where, your record is easily accessible by a whole range of people who need to see it.
Yeah. At the same time, though, one of the other challenges about technology, healthcare technology, is that, back in the paper and paper age, it was possible to lose a medical chart. These days, you can lose 10,000 of them on a USB key. There's a big difference between an application being created and an application being created and done well. So, for example, our 25 years, 30 years of experience with Microsoft at this point has led us to very low expectations and a lot of skepticism that if a health record is going to be implemented, it will be implemented properly. I think that these are all very good points, but I think at the same time, though, part of inspiring enough confidence in the concept is to be able to address the fears at the consumer level that bad implementation will do more harm than good.
Right. Yeah, please.
Hi, I'm Melissa Karjanakis from the Ministry of Economic Development, but I'm also finishing my master's thesis on we did a pilot RCT in the United Kingdom on diverting people from readmission to hospital with early stages COPD. And unfortunately, the data analysis so far is actually saying that the experimental group was actually going to the hospital more than the control group because they had the in-home medical device that was giving them information about how they were doing and generating alerts. And while I empathize with policy concerns about trying to keep healthcare, less than 40%, or at least at 40% where it's at right now, or bring it down. I'm curious as to what your thoughts are of how to manage that price when in reality, paying for a physician to look at metrics later at night, paying for a physician to also use the telehealth remote psychiatry, in addition to all the things they're already doing. Is there a way that you don't actually cause a dramatic increase in cost? And in terms of the efficacy of some of the products that you were mentioning at TELUS in terms of actually reducing readmission rates? And some of my findings are saying there's more, and I'm just curious about your thoughts on that, I guess.
To me, to start? I think your concern and your questions are very valid, and I think you got to look at the total picture in terms of what the full program means. If we look back in history when all the images in radiology went electronic, what they didn't keep in mind, increased throughput meant that the physicians and the specialists could do more volume. They didn't bring the fee code down, so the cost went up by 25-30%. So I think we have to learn from the past. I do think we have to look at the total picture and apply where it makes sense and where it doesn't. And I don't know the specific piece, but I think your point is valid, that this is not simple and it's not straightforward, and I think we have to look at the new ways. The physician that used to work 7 hours a day that's now got 3 hours of electronic work at the end of the day probably doesn't like that. So how do we change things and put the pieces in? Last thing I would say though, there's a lot more demand. So it's all very well to say we're going to stick at 40%. I look at myself, sandwich generation, kids in hitting their teens and parents in their 70s. We're right in the middle of it, and it's not going to be easier over the next 10 years for my parents. The system's going to have to deal with it. So how are we going to grow? But lots more thoughts and careful steps forward is important.
No, I would just, first of all, congratulations. It's not easy to run a trial like that, and I'm thrilled that you're part of the Ontario Public Service because we need people who are at the forefront of that kind of work. I would say a couple things. We look to organizations that are ahead of us in this regard, and you probably know a lot of these, but they're in places like Intermountain Health and Kaiser Permanente and Geisinger that, again, all tend to focus more on an outcome-based reimbursement model. The additional assessments under a fee-for-service model are very prone to escalation. I mean, we know that, we've seen it, and that's just a fact, and Fraser's points are well taken. And I think you give us an important reminder, too, that as we start to look at different kinds of models, some of them won't work, some of them will cause an increase because there was a big unmet need that is now being filled, and it's just being thoughtful as we go forward and knowing that not every piece of technology is going to bring about something positive, because at the end of the day, changing behavior is the hardest thing that you can do, particularly in healthcare when a lot of the behaviors are things that people don't necessarily want to do. I think Apple and every other company they have it so easy because they're helping people do what they want to do, find their music more easily, find entertainment more easily. But when somebody is trying to deal with depression or a complicated set of tasks before surgery, those are not necessarily something that people want to do, and that's extraordinarily difficult. So the blending of the design and the different kinds of coaching with the technology is critical.
So one more comment. We've got about a minute left. David, do you want to have a go?
Keep it quick, yeah. So the other thing, of course, is also patient-level factors, right? So for example, we're doing a study right now looking at self-management of depression. One of the folks who was involved in our study pointed out that those who are more prone to brooding about things may see 3 points starting to form a downward trend, thinking, I'm getting depressed, and then off to the hospital they go. So, it's important to starting to try and tease apart for which kinds of people is application A more appropriate, for what kind of people are another kind of application more appropriate. Patient-level factors are important.
Just to respond to that, with the outcome-based funding models, that is going to be actually critically important. And something that's interesting, though, just one comment, would be curious about how physicians and healthcare providers feel about almost like putting their, paychecks on the line when the patient does have to meet them at least some of the way. And it sounds a little bit like social impact bonds that we're working on at the ministry, and how your investors only get their money back if a specific social, particularly challenging social problem is at least solved or minimized to some extent. So it's just interesting to see that all the tailoring and customization that you're going to have to put into what path works best, especially if we're looking at outcome-based.
Can I have 15 seconds to respond to that?
Sure.
Okay. I think that regardless of compensation models, physicians want to do the best by their patients, right?
Yeah.
So regardless, we're interested in what's going to work best for somebody, and it's going to be stupid for us to try and use something which isn't. So, I think that, again, it comes back to the fact that the basic research on what's going to work for who is critical.
That's a great final point, and we'll leave it there. Thank you so much for all of your great questions. I'll call Vanessa back up to sign us off here.
Perfect. So yes, thank you to all the panelists and to everyone coming out here. I think just the turnout, the caliber of the discussion, and the caliber of the questions really emphasizes the relevance and the importance of these issues that we're talking about. And I need to just, rather than recapping what I've heard, I think we need to applaud the government for actually adopting in the budget last week all of the recommendations under the OHIC report. And I know there's challenges ahead. I'm not going to be delusional in that way, but I think we can only acknowledge that's a very positive step, and I think everyone here should be happy to see what comes from that. So again, just thanking our panelists, Pat Clifford, Dr. David Krindler, Fraser Edward, Dr. Michael Hilmer, and Dr. Joshua Liu. We greatly appreciate you taking the time to be here today and share your insights, and as well to Matt for keeping us on time.
Thank you.
So
Right on.
got a quick gift for you all. All right.